in whom there is the greatest likelihood of finding cancer is still the subject of considerable disagreement. And depending on where you are in your clinical practice with thyroid nodules and thyroid cancer, you might agree with me that we're still very much in the same sort of boat. And for many years, we didn't do a very good job with this. So this is data from about 30 years ago, which was something very typical at the time, if you're old enough to remember that, where we would do cytology diagnosis and find quite a number of cytologically indeterminate specimens, for which we would then offer diagnostic lobectomy. And in 80 to 90% of those cases, we found histologically benign thyroid nodules. And we congratulated ourselves and the patient for not having cancer, even though the patient had a permanent scar and may have suffered some injury during surgery. And we all knew there was a better way. In the early to mid 2000s, we, along with many others, started recognizing that in a large number of thyroid cancers, for instance, for papillary and follicular cancer, which comprise about 95% of all thyroid cancer, a small repertoire of genetic alterations explained the vast number of those tumors with very high specificity. So we started using this diagnostically very early in the 2000s, and as technology improved, including next generation sequencing that made massive parallel sequencing a possibility, things progressed from there. In 2014, the Thyroid Cancer Genome Atlas, which we participated in at the University of Pittsburgh, identified that for about 500 early stage papillary cancers, many of the genomic drivers that caused cancer could be identified. And in most cases, 75% of the time, these were single nucleotide variants or point mutations. And you're all familiar with molecular alterations like BRAF mutations, RAS mutations, et cetera. Another 15 or so percent could be explained by gene fusions, such as RET-PTC, PAX8-PPAR gamma, NTRK fusions, et cetera. And copy number variations also comprised about 5% of what was found. And these had particular importance, not only in papillary cancers, but in Hürthle cell tumors, which I'll talk about in a minute. But the take home was that about 95% of these early papillary cancers could all be identified with discrete mutations that could be easily identified with these modern sequencing methods. So Thyrosiq actually evolved by understanding the predictive value, and as I'll talk about later in the talk, the prognostic value of these mutations, and being able to harness them and put them on a diagnostic platform that was very much driven by this incremental process of gene and molecular alteration discussion. We also learned some other very important facts about thyroid cancer that from the Thyroid Cancer Genome Atlas project, we were able to understand tumors that behave more BRAF-like or more RAS-like, two discrete single nucleotide variant mutations that I'm sure you're familiar with. BRAF-like tumors have the classic features of papillary cancer. If you take a look at these photomicrographs, you can appreciate that these look histologically like papillary tumors with papillary fronds. They're very dark from all of the nuclear expansion. And if you look at them ultrasonographically, they have the very classic features of papillary cancer. Spiculated margins, very irregular borders, very hypoechoic. There are microcalcifications in these tumors. These are classic variant papillary cancers with the classic nuclear features. They are infiltrative and very readily spread to local regional lymph nodes initially and much later to distant sites. But importantly, they de-express the genes associated with thyroid differentiation. And this conveys some important prognostic information. So things like sodium iodine symporter are de-expressed, suggesting that these tumors respond less well to treatments like radioactive iodine. On the other hand, RAS-like tumors look very different under the microscope, but also very different under ultrasound. They're very dense, solid, homogeneous, isoechoic, sometimes hyperechoic tumors. They are encapsulated. The nuclear features of papillary cancer are absent, and these in fact look like histologically follicular neoplasms. They do spread to distant sites because they're hematogenously spread and less commonly to local lymph nodes. and they retain expression of the genes associated with thyroid differentiation. So you might guess, and you'd be right, that these RAS-like tumors generally, unless they are widely metastatic, will respond much better to radioactive iodine than these BRAF-like, papillary-like tumors. We also started learning that there were important pieces of information about prognosis that we could understand and divine from the molecular genetic endowment of these tumors. And this is specifically about the TERT promoter mutation. There are 3 panels here. I'll direct your attention to this one on the right. And what you can see in all of these is that when TERT mutations are present, specifically when they're present in combination with either RAS mutations or BRAF mutations, recurrence-free survival is worse. Mortality, overall mortality is worse. And if we look at a group of patients with American Thyroid Association high-risk disease, so very aggressive invasive disease, those that have TERT mutations, in addition to that aggressive disease, have an overall poorer disease-specific survival compared to tumors that look exactly the same, but lack the TERT mutation. So important prognostic information that we're now understanding from these genetic markers as well. We've also understood a lot about Hürthle cell tumors, which has been a very frustrating tumor for diagnosis and treatment as well. We know that there are mitochondrial DNA mutations that are sort of unique to these Hürthle cell neoplasms. But one of the most important diagnostic findings and even prognostic findings are chromosomal copy number alterations. So we all know that we inherit one copy of a gene, one allele from our maternal parent, and one copy of an allele from our paternal parent, our mother and our father. And you can see that in this top box on the right, one chromosome is colored brown, one chromosome is colored green, and when those cells divide and undergo mitosis, that is respected. With copy number variations, one of those alleles can be lost, leading to a haploid genome. In a more advanced case, that single remaining allele can duplicate itself, which is completely abnormal, leading to something called uniparental disomy. And these are hallmark findings of Hürthle cell neoplasms and Hürthle cell cancers. When you superimpose the presence of mutations like single nucleotide variant mutations, point mutations in BRAF, P53, TERT promoter mutations, on top of those chromosomal copy number alterations, you now have identified a unique set of Hürthle cell neoplasms that are the most aggressive and typically metastatic Hürthle cell cancers. So this information, which is uniquely obtained through this type of genomic analysis, can be very helpful not just for diagnosis, but for prognosis as well. So sort of the 5 domains, diagnostic domains that are so helpful for diagnosis and prognosis are these. Point mutations such as BRAF, RAS, and others. Indels, small insertions or deletions into genes. Gene fusions, these copy number alterations that I just talked about. And gene expression changes which can relate to various gene pathways that can be expressed or de-expressed in benign and malignant tumors, as well as the expression of genes such as calcitonin, which can be useful for diagnosing medullary cancer, or parathyroid hormone for parathyroid tumors of various types. And suffice it to say that in our experience, the most helpful way for diagnosing these genetic alterations, finding these genetic alterations, is through the use of both DNA and RNA to give the most robust diagnostic tool that's available. So that's really what ThyroSeq is. It's a next generation platform that uses both DNA and RNA to leverage the advantages that each discretely provide. And it's a panel that first assesses adequacy of the specimen. So when you submit a ThyroSeq specimen, the first step is determine whether there's an adequate cell count in the specimen. If that is true, then the tool can discern whether those cells are thyroid in origin, something other than thyroid in origin, like a metastasis, and whether it may be something unexpected in the thyroid gland, like a parathyroid gland, a medullary thyroid cancer, which is more of a neuroendocrine tumor. If there is an adequate specimen of thyroid cells present, The main classifier, which is 112 thyroid-related genes, including over 12,000 point mutations, over 500 indels, over 150 informative gene fusion products, and a copy number assessment evaluation and gene expression evaluation, all then analyze the specimen. And the results are compared to something that I think is quite unique. It's a proprietary database at the University of Pittsburgh that allows correlation between the cytology results and over 3,000 cases with known surgical outcomes and prognosis. And that is one of the fundamentally important things about ThyroSeq, is that I know of no other database that's that extensive that allows this sort of prognostic understanding of the significance of these various molecular findings. It's important to note that each ThyroSeq case is curated, it's formulated, and it's signed by a molecular pathologist that is licensed in the United States. This is not a machine-generated report. This is constructed by an actual person who looks at this information and interprets it for you in a very clear report that I'll show you in just a bit. The report will give you a readout of either positive or negative. Importantly, in that single report, you'll also receive detailed information about the actual molecular genetics, genetic alterations that are present. You'll get a specific readout of cancer probability and cancer reoccurrence, and also recommendations for potential clinical management. What kind of samples can you submit for ThyroSeq? Well, typically it's a needle wash in ThyroSeq Preserve, a nucleotide solution. That's the most common type of sample that's submitted. It is validated for a single needle pass, unlike some of the competitors that require multiple needle passes. It can be stored at room temperature for up to 3 hours and in a freezer for up to 12 months. And in fact, in a minus 80 freezer for even longer. You can also submit fixed cytology smears that are pap stained or diff-quick. It takes just a little bit longer to process those because there's an extra step of nucleotide extraction that has to take place. And ThyroSeq has also been validated on resected formalin-fixed paraffin-embedded tissue and FNA cell block as well. All of these specimens require about 200 or 300 cells. That's not very many when you do a typical FNA or submit a slide or a piece of FFPE tissue. Any of those are available. And if you have specimens that you want analyzed, you can contact Sonic and they can explain to you how to get the specimen to the lab for evaluation. What about test performance? Well, the gold standard validation for this study was published in 2019 in JAMA Oncology. It included 250 approximately thyroid nodules that were primarily Bethesda 3 and 4 with a few Bethesda 5 cytology specimens. This was a prospected, double-blinded, multi-center study that even included one international site. All the specimens underwent central pathology adjudication by 3 pathologists. The primary outcome was accuracy of detection of cancer and NIFP, so a positive surgical diagnosis. And importantly, there were no post-unblinding exclusions from this study, again, unlike some of the other studies that compete in this space. It demonstrated an excellent sensitivity of 94%, negative predictive value of 97%, and a specificity of 82% and positive predictive value of 66%. I want to call your attention to its performance in Hürthle cell tumors specifically. ThyroSeq has been extensively validated on, I think, the largest series of Hürthle cell neoplasms and cancers that I know of, used for analytic validation. This is the clinical validation, the real world study, where the ThyroSeq tool was able to correctly identify 5 out of 5 Hürthle cell hyperplastic nodules as benign, all 10 Hürthle cell carcinomas as positive, and about 2/3 of the Hürthle cell adenomas as benign clonal neoplasms with an excellent sensitivity of 100%. So maybe in a more real world sense, we can understand ThyroSeq by looking at 100 imaginary patients who undergo ThyroSeq testing. Of those 100 patients, 61 patients will receive a benign call. So this is the benign call rate of Thyrosiq, and those patients can avoid surgery. You'll notice in this left-hand block, all the green figures are benign, true benign cases. There will be 2 cancers that are missed with a false negative call. This is about a 3% rate, which is equivalent to benign cytology, microscopic cytology. So this is acceptable. It's basically the equivalent of the false negative rate of a negative cytology call from a pathologist. It'll correctly identify 82% of all histologically benign nodules as test negative. On the flip side, 39% will have a positive result, meaning these are clonal neoplasms. And when these 39 patients go to surgery, about 2/3 will turn out to have surgically positive disease, meaning cancer or NIFT-P, at a disease prevalence of 28%. So overall, I think extremely useful, very important benign call rate to avoid surgery, and a very high surgical yield rate among patients who do require surgery because of a positive test. In addition to the double-blinded prospective multi-center study, there have been a number of really well done, investigator-initiated, independent validations of ThyroSeq as well. These are 3 from the University of Pennsylvania, from Montreal, and from Los Angeles. And importantly, the negative predictive value, positive predictive value, as well as the underlying sensitivity and specificity and the benign call rate are very similar among all of these independent validation studies, backing up the findings as published in JAMA Oncology in 2019. If we just quickly compare these to 2 other tests that are available on the market, the Afirma GSC, the latest iteration of Afirma, and the Interpace MPTX panel, you can see that the negative predictive values at any given prevalence of disease will cluster pretty closely. Certainly, Thyroseq arguably has a better positive predictive value, and I think that's one of the many strong points of this test to consider. But what about prognostic utility of Thyrosiq? I've talked about that a couple of times so far. I think we're all increasingly understanding that the punishment should fit the crime, that the intensity of therapy should be matched to the aggressiveness of disease. And in fact, in the 2015 ATA guidelines, the recommendation was that lobectomy alone may be reasonable for low-risk papillary and follicular cancers. But the question is, how do you determine what a low-risk papillary or follicular cancer is prior to surgery? Well, the obvious answer is molecular diagnostic testing. And we know that the actual genetic alterations that ThyroSeq reports out can be subclassified into risk stratified groups, such as a high-risk group, which are the compound driver mutations that I spoke about before, BRAF and TERT, PIK3CA, P53, others. The more BRAF-like group that behaves more like conventional variant papillary cancer, the RAS-like group, which is a more intermediate predictor of cancer and for lower risk cancer, and then the copy number group that's associated with Hürthle cell neoplasms and Hürthle cell cancers, and then the gene expression alteration group, which are where we find things like medullary cancer, parathyroid tumor, and metastases from other primaries. The ATA has also given us this rubric for stratifying risk, primarily based on histology and light microscopy. But you can see that gene-identified genetic alterations such as TERT and BRAF are now included, or BRAF wild type, which conveys a low risk. But what I'm explaining is that we can also take results that ThyroSeq will produce and superimpose this on the same risk diagram, where the highest risk tumors are those with these mutations. The BRAF V600E-like tumors are more intermediate risk, and the RAS-like tumors are the lowest risk. And in fact, Lin Yip, one of your colleagues, published just this year a very important study that looks at 5-year risk of distant metastases as stratified by the presence or absence of these genetic markers. And she found that the highest risk of 5-year distant metastasis was in this group, perhaps not surprisingly, and the lowest risk was in the RAS-like group, with a more intermediate risk in the BRAF-like group. And I think that it shouldn't be hard for you to imagine, and I certainly find this as a clinician, that this is exactly the kind of information that I want to be able to put my hands on when I'm explaining prognosis and possible outcomes to a given patient with specific disease. So what about molecular markers for therapeutics of cancer, another growing and very important area of treatment? Well, we know that there are now FDA-approved therapies that can specifically target certain mutation types. So dabrafenib is a BRAF V600E inhibitor. When coupled with a MEK inhibitor, trametinib, it can be used for BRAF V600E tumors. There are 2 NTRK fusion drugs that are highly effective for NTRK fusion, often metastatic tumors. There's a recently approved inhibitor for RET fusion drugs, and there are some off-label targeted therapies that are available for treatments like tumors with ALK fusions, such as approximately 4% of anaplastic cancers that carry ALK fusions, where drugs can be very useful, and in that small percentage of patients, often very effective. So how about individualizing patient management using a tool like ThyroSeq? Well, when the ThyroSeq analysis is done, the readout will first report out whether you're dealing with a non-thyroidal tumor, and if so, what it's likely to be. If it is a thyroid specimen, many patients, 61%, will have a benign call, a test negative result, where there is a small residual cancer that's approximately equivalent to microscopically benign cytology, and the recommendation in that case is for continued observation. There is a classification called currently negative, and what this is a group of tumors where there is very low level expression of a neoplastic clone, where the tumor is not likely to widely express that mutation. And while that tumor is likely to be benign at that time, there is the possibility that it can change. So active surveillance is recommended for this group. And the remaining results will all be some shade of positive. So if you start on the right, those are the very high risk tumors where the finding of multiple compound driver mutations is highly predictive for highly aggressive tumors. And the recommendation in that case is for total thyroidectomy with consideration of lymph node dissection. The next is a BRAF-like group where total thyroidectomy or possibly lobectomy, depending on clinical factors, would be appropriate. Hürthle cell type tumors where there's information about whether it's likely to be a lower risk or higher risk tumor, such as a Hürthle cell cancer. And then the RAS-like group with a more intermediate predictive risk for surgically positive disease. The ThyroSeq report is clear. The report includes the test summary. So this is a positive result where you can see that the test result is positive. The probability of cancer in this case is greater than 95%. Surgical excision with some explanation below is recommended. There's an interpretation of the results and an adequacy statement, so showing you that this specimen was indeed adequate for interpretation. And then the interpretation, and this is the part that's formulated by an actual molecular pathologist, explaining that in this specimen that contains both a RAS and TERT mutation, RAS is generally a very early oncologic driver, and TERT is typically a later genetic event. And the combination of these two convey an extremely high risk of aggressive disease. And then down below, you'll have the actual printout of the types of mutations that are present, the affected codons, and the allelic frequency, how prevalent the noted mutation is in the specimen. So this is the last slide. It's just a summary. What I hope I've conveyed in the last 25 or 30 minutes is that ThyroSeq is the highest sensitivity and negative predictive value test that is available among commercially available, well-validated tests. It is reliable for diagnosis of all types of thyroid nodules, including Hürthle cell tumors of all types. It can be used for diagnosis of medullary cancer, parathyroid tumors, as well as non-thyroidal lesions such as distant metastasis. It has a high benign call rate, which avoids surgery in the majority of cases. It uniquely reports the diagnostic probability of cancer as well as prognosis. It can detect therapeutic targets for targeted therapy in advanced thyroid cancer cases. It offers the most flexibility of any commercial test in terms of the sample types that can be submitted. And ThyroSeq very appropriately informs more individualized management of patients with thyroid nodules and cancer in a single diagnostic comprehensive test, because it reports not just results, but the actual genetic alterations that drive these tumors. So with that, I will thank you. And if there are questions, I think we have a few minutes, and I'm happy to have them if any of you are interested.
Great, thank you, Dr. Hodak. We have about 2 minutes for questions. It looks like we do have one question in the chat that asks, if the test comes out negative, is it necessary to repeat it in the future during follow-up?
Well, I mean, if the test comes out negative, you're either dealing with a true negative, which excludes the possibility of neoplastic disease, or in very rare circumstances, a false negative, right? And this is the same as looking at a tumor under the microscope and saying that it's benign. There's still an occasional tumor that will escape detection. I would suggest that a tumor based on its clinical features, whether it looks suspicious on ultrasound, whether it's growing over time, whether you know that there are some specific clinical factors that concern you about that tumor, that should factor into your decision about whether or not you need to repeat an aspiration, and if so, repeat ThyroSeq diagnostic testing.
Great, thank you. I don't see any additional questions coming in. So with that, I will thank you, Dr. Hodak, for your presentation today. And thank you again to Sonic Healthcare USA for their silver level support of the AAES 2021 annual meeting. If you do have any questions for Sonic Healthcare, I encourage you to chat or reach out to them in their virtual sponsor booth in the meeting platform. Beginning next, we have the How I Handle It Tips and Tricks for Challenging Operative Scenarios session, moderated by Kwan Yang Du. Head back to the agenda to join that session live now. Thank you.